Great. All right, so I just want to welcome you all, thanking everyone for again joining in. And I would like to call this webinar to order. It is now 12:25. So special welcome to you all. Again, thank you sincerely for joining with us here at Spanish Town Hospital. I believe I've lost count. I should introduce myself. I'm Dr. Wright James. I believe I've lost count. I believe this is probably about our eighth webinar. And of course, it all began with COVID-19, which started, as we know, last year, March. We will have 4 sessions today. And the title of our webinar today is Lifestyle, Legacy, and New Norms. COVID-19 we're hoping for a normal. I don't believe that that's going to happen. See how best we can learn to live in this new situation. We're going to ask you as usual on entering for registration purposes to enter your name and to enter your email address, and this will facilitate you getting your CMEs. So please remember to do that. We're going to also put a survey in the chat so that you can fill out at the end. You can fill it out as you go along, because we do value your opinion and help us to improve for each one going forward. Just a few housekeeping points. I think we're all experts now on this webinar, whether it's Zoom, platform it is. And we're going to ask so that we can benefit all together to remember to, except of course for the presenters, that all microphones should be kept muted and all videos kept off. There are designated times for question and answers, and we ask that you type your questions in the chat beforehand. And as I told you, the CMEs will be sent out electronically, so remember to put your emails. I'm going to, without much further ado, hand over to our most able moderator, our Director of Nursing Services, Ms. Novelette Robinson, who is going to ensure that we stick to schedule, we keep in tow. We have a long afternoon ahead of us, and we're aiming to finish on time. So I hand over now to our able moderator. I am out, and I thank you for joining in again, and have a great afternoon with us. Over and out. Thank you.
Good afternoon, ladies and gentlemen. Welcome again to our webinar, our motivational webinar that we have started over a year ago. And that was a bit of a setup just now by our SMO that I'm going to keep you all in tow with the time. That was a big setup trying to tell me that I must remember the time, but I take note of that. Today, we are going to be looking at our, as mentioned earlier, the lifestyle, legacy, and the new norms, which we have acquired over a year ago since we started the seminar, which was since COVID came about. We're going to be looking today, we're going to be focusing on when to switch medications from IV to oral, and how safely we do so. We're going to provide updates on migraine headaches, as well as the long-lasting effects of COVID-19 pandemic. We're going to explore ways to prioritize activities, very important, making timely decisions and managing that challenging lifestyle. Are you hearing me? You're hearing? Great. So before we go, I want to again thank Dr. Wright James and her team again once more for setting up such a webinar. One of the very important factors with this webinar is that it is still free, and you also get your continuing educational hours. So before we go any further, I am going to ask Mrs. Michelle Rowe to come and invite God's presence in our midst. Mrs. Michelle Rowe is head of our physiotherapy department, and she will come and invite God's presence.
Good afternoon, everyone. Let us bow our heads for prayer. Dear kind, righteous Father, we are so grateful, Lord, for all your blessings upon us. We thank you, Lord, for life. We thank you for the opportunities that you have provided us from day to day. As we come now, we acknowledge our sinfulness, but we also recognize, Lord, your grace and your mercies towards us. And so, Lord, we ask your forgiveness of our many sins. I invite your presence to be with us in this education session. I pray that you would bless the presenters. I pray that you would bless the entire proceedings, and may each of us benefit fully from what is prepared and presented today. Continue to be with us and bless us all, we pray. In Jesus' name, amen.
Right, we have 4 aspects that we will be going through today. And the first one is that which will be done by Dr. Joseph Morrison. But there's someone who is tasked with introducing Dr. Morrison to you. And we're going to call again on Mrs. Michelle Rowe to come and introduce our first presenter, Dr. Morrison.
Okay, are you hearing me? Can I go ahead? Are you hearing?
Yes, I am hearing. Yes, I am hearing.
All right, go ahead. Okay, so Dr. Josette Royal Morrison is a proud graduate of the University of Technology, Jamaica, where she completed her Bachelor of Science degree in pharmacy and later her Doctor of Pharmacy degree. Dr. Royal Morrison has practiced as a pharmacist in both the public and private sectors. With the public sector, she has served at different levels, including chief pharmacist with the Ministry of Health at the Spanish Town Hospital and Bellevue Hospital. She's also presently serving as a clinical pharmacist with the National Health Fund at the Spanish Town Hospital. Additionally, Dr. Royal Morrison lectures part-time with the College of Health Sciences at UTech. Dr. Royal Morrison has conducted many workshops and training sessions, including 2 workshops on thyroid disease and a workshop entitled Depression in Adults, the Role of the Pharmacist. The role of the pharmacist with antipsychotics. Pharmacists educating patients on the management of metabolic abnormalities. Dr. Royal Morrison presently serves on several professional bodies, including the Public Relations and Public Education Committee, the Editorial Committee, and the executive body of the Pharmaceutical Society of Jamaica, as well as a member of the Education Committee for the Pharmacy Council of Jamaica. She is currently a director of the Kiwanis Club of Old Harbor. I ask that you now give Dr. Royal Morrison your undivided attention as she presents to us on making the switch, IV versus oral. Dr. Morrison.
Thank you so much, Mrs. Rowe. Good afternoon, everyone. So today, as you've been told, I'll be presenting on making the switch, IV to PO. Now, the objectives for today, we should be able to explain IV to PO conversion therapy, common misconceptions, advantages of IV to PO conversion, differentiate between the types of IV to PO conversion therapies, identify common medications, including an IV to PO conversion program, and determine suitable patients based on particular inclusion and exclusion criteria. So the route of administration for medication that is chosen is one that you'd expect to give the highest outcome, the best outcome with minimal adverse effects for our patients. Many of our patients, especially those with infections, once they're admitted to the hospital, we normally initiate their therapy using intravenous therapy, and then we would consider changing these patients to oral therapy. So what is IV to PO conversion therapy? It's the process of reviewing patients on select intravenous medication, assessing their eligibility for conversion to POs, and we find that it's most widely used when we speak about our anti-infectives or antibiotics or antivirals or antifungals, but it may also include our GI medication, cardiovascular, neurologic, or endocrine drugs. The IV to PO conversion therapy is used mainly when we have short IV courses, such as our antibiotics for 2 to 3 days, and then we are followed by oral medication to complete the patient's course. However, in as much as this has its benefits, it's not ideal for everyone. So we find that it may be inappropriate for a patient who is critically ill or one who has inability to absorb the oral formulations. But we find that some persons are reluctant to change the patients, and that could be based on certain misconceptions that our physicians or practitioners in general may have. So let us look at some of these common misconceptions. IV anti-infectives are more effective than oral anti-infectives. Is that the case? I see someone saying yes, but clinical data has actually shown that that is not the case. So there are oral therapies that are just as therapeutic effective for patients as the intravenous therapy. But we must be guided in when to initiate the oral therapy, because we need to ensure we maximize our tissue penetration before we switch to oral therapy. All patients with an infection need IV treatment. I think we've bypassed that by now. Many persons are now initiating these patients with oral therapy. Same agent must be used both IV and orally. So if I initiate a patient on ceftriaxone, for example, IV, I'm thinking that the patient must continue on ceftriaxone orally. Is that the case? No, it's not the case. Great. Conversion should only be made at discharge. Is that the ideal time for us to make the conversion? No. You can make the conversion while the patient is still in an inpatient setting. But as we had said before, there are many advantages. And so we're going to look at some of these. Improved patient comfort and mobility. I don't know how many persons are like me, but anything to do with needle, I despise. And so having a needle in your hand is not something you'd want. It's very uncomfortable for many. And when you have the IV poles there, it makes movement very limited. So one of the advantages in switching to oral is that you have improved patient comfort and mobility. There's a decreased risk of infection from the IV lines, because you'd have had persons who would have had these in and they have the risk of developing other infections, which could make their conditions worse or could also lengthen the stay of their hospital. Decreased risk of thrombophlebitis, and we know how that goes already. Lower cost of therapy, because it's not just the cost of the drug that is less, but remember now you won't need your IV needles or giving sets. You won't need to be monitoring as much as you'd normally be monitoring the patient. Consider the patient is now on oral therapy. And so you recognize that the cost overall will be reduced. It may lead to earlier discharge because they are now able to see how best the patient is responding on this oral therapy. And so the patient is able to be discharged at an earlier time. Reduced risk of missed doses. We do have cases in which the IV access, for example, might have fallen out, and so the patient would have missed some IV doses. If it's oral, because of the ease of administration, this is minimized. Reduce preparation and administration time. So our nurses and our physicians could utilize that time now to do other functions that can be more critical. We spoke about IV to PO conversion, but is it only one way we can do this, or are there different ways that this can be done? So there are three main types, and we're going to look at those three types. The first is a sequential therapy. So you change from the parenteral drug to its oral form. So the same drug in IV to the same active ingredient in the oral form. Then you have what is considered a switch therapy. So you change the patient's IV drug to an oral drug within the same class that has the same potency. And then the third type is your step-down therapy. And here you change the IV drug to an oral drug, but this can be in the same class or it can be in a different class. And when we talk about antibiotics, it doesn't have to have the same spectrum activity, so that can be different. The dose and the frequency can also be different. And we're going to look at some examples of these now. So when we talk about sequential, if you recall, it is the same drug from IV to the same drug in PO. So levofloxacin 500 IV Q24 hours to levoflox 500 milligrams PO Q24. Or utilizing your GI drugs, you have pantoprazole 40 milligrams IV OD to pantoprazole 40 milligrams PO OD. When we talk about our switch therapy, we had said it should have been in the same class with the same amount of potency. So you're moving from a levoflox 500 IV Q24 to ciprofloxacin, for example, 500 PO Q12H. Or you can move from pantoprazole IV to your omeprazole PO. So you're looking at the same class of drugs, but giving it at a different route, and it has the same amount of potency. The third type we had spoken about was a step-down therapy. So an example here is from ampicillin sulbactam 3 grams to augmentin amoxiclav 1 gram POQ12H. So it's a different class. It has different spectrum of coverage, but it's able to treat the current infection that this patient has. And oftentimes we may initiate patients' therapy empirically. You come in, we suspect a certain condition, and so we start high to ensure there's coverage. When the results come back from the lab, the CNS comes back, we can step down now to something that gives the adequate coverage for whatever it is that the patient has. All right? So what are some of the common medications for IV to PO conversion? And we're not just gonna name them. We want to look at how these drugs are determined to be included in a protocol, for example, that is had at certain institutions. And this is probably the way that Dr. Wright James would want our facility to go. So what are the characteristics? The drug should have an excellent bioavailability. So ideally it should be in excess of 80%, but there are some that may fall within 70% that are still utilized for these IV to PO conversion. should be well absorbed, well tolerated, and most importantly, it should be supported by clinical data or literature review. If, for example, a certain condition, the oral formulation is not recommended, there is no reason for you to switch that patient from IV to PO. Now, other factors are optional, whether or not the drug has multiple oral dosage forms. So you want to know if it's available in tablets, for example, chewable tablets, capsules, or suspensions for ease of therapy, ease of administration, depending on the patient that you may have. Also, one of the things that persons may consider is that the frequency of administration should be less than or equivalent to the IV, but it's not necessarily important that that be one of the factors. Now, oftentimes, as we had said before, we utilize the IV to PO conversion for our anti-infectives. So we had mentioned levofloxacin, but also your antifungal, your fluconazole is an example. Your GI drugs, so you have pantoprazole. And in cardiology, you could include, for example, your digoxin, your metoprolol. In neurology, your phenytoin. In endocrinology, your dexamethasone as well. And I mentioned dexamethasone here, and dexamethasone can either be moving by the same drug, so you're sequential, or you can have a switch in which you change it to a different drug within the same class. The bioavailability of a drug plays a very important role in determining when to switch or if the switch can take place. And the bioavailability refers to the amount of the oral medication that actually reaches the systemic circulation. So for your IV drugs, it's going directly to the blood, and so it is always 100%. But when we consider our oral route, there are different factors that may affect the amount of the drug that actually reaches to the bloodstream. And so this has to be considered in determining what dose of the oral equivalent will be administered to the patient, prescribed and administered to the patient. So you have factors such as the rate and the extent of the solution, the amount that is absorbed into systemic circulation are some of the factors that are considered. But as we had said before, it's not something we can give to everybody. Patients should be able to meet certain characteristics in order for us to do this conversion. So what is it that we look for? Basic criteria used to determine whether or not the patient is eligible for oral therapy. The patient must have an intact and functioning GIT. So if the patient has any condition that prevents them from absorbing this medication, we cannot give them an oral medication. The patient should be improving clinically. And if the patient doesn't meet any of the exclusion criteria, so we're going to look at what some of these inclusion and exclusion criteria are. So when we screen our patients, we have to look at the type of infection that is suspected. As we had said before, not all infections can be treated orally. Some infections are best treated intravenously. The duration of the IV antibiotics that has been received to date. So the patient usually gets 1 to 3 days before considering switching the patient to oral therapy. Has there been any form of clinical improvement? If the patient's heart rate is not improving or the respiratory rate, you would want to ensure that this patient is more or less stable before you determine it's time for us to make this switch. So we want to have the vitals being stabilized, and the patient should be afebrile for at least 24 hours. And for this one, I want to add something. Afebrile at least 24 hours, but we need to consider if the patient was on any antipyretic. Because if the patient is on antipyretic, you may use that false link saying that the patient has been afebrile for 24 hours. Is the white blood cell count improving or not? Symptomatic improvement. So when you look at the patient, we check the symptoms of the patient. Are they improving? Is the patient's mental status improving? Are there any allergies? Because if we're changing the drug to a different drug, we have to consider whether or not the patient is going to be allergic to this new drug that will be administered. Consider medication profile. So we have to consider the drugs that the patients is currently on to determine whether or not we're going to have any drug-drug interaction taking place. The labs, and here we include the renal and the hepatic function, because if we need to do dosage adjustments, we must be aware of the patient's renal and hepatic function to know, yes, the recommendation is a one-to-one switch, but because this patient has renal impairment, we're gonna have to give the dose based on the recommended dose for this renal creatinine clearance, for example. Ability to swallow or receive enteral feeding, and I wanna add something here. Oftentimes, the patients are on NG tubes. And as physicians, we do not consider the type of formulation that the patient is being prescribed, whether it's a slow release drug or if it is enteric coated, because those should not be crushed. So it's not just a matter of just say, oh, the patient is diabetic, let me write some Dimicron. No, you must consider the patient has in an NG tube. Dimicron is a modified release drug. If we write for this and the nurses have to crush it, the patient may become hypo initially and then have spikes, because what is going to happen is that the full amount of the drug is not going to be released to the patient at once, as opposed to if it was still in its intact form, it would release small portions over the 24-hour period. So we must be mindful of the formulation that we're switching the patient to when we talk about patients who have enteral feedings. The sensitivity profile of the infecting organisms. So yes, we can change the patient orally, but we did the CNS. Is the organism sensitive to the drug that we want to change the patient to? Is there an oral formulation for the drug that the patient results came back as being sensitive to? We have to consider all these things in switching the patient. So let us look at some of the exclusion criteria. There is no oral formulation available, and oftentimes we may have that challenge, and so we maintain the patient. So if it's not one that we can do a step down for, we have to maintain the patient on the IV therapy. If the patient is clinically unstable, yes, we have to maintain the patient on IV therapy despite having gone to 2 or 3 days of IV until the patient is stable enough to receive oral therapies. Is the patient NPO? Is the patient still nauseated or vomiting or having diarrhea? Because all of this is still going to impact the amount of drug that is actually absorbed by the patient. Is the patient at risk of aspiration? You don't want to give that patient something orally. Is there any abnormality in the GI system anatomy? Does the patient have a history of colectomy? In those cases, you want to avoid giving that. And let us look at some more. Does the patient have any malabsorption syndrome? Is there any GI obstruction? Does the patient have an active GI bleed? Is the patient receiving or requiring continuous gastric suctioning? Is the patient getting high doses of vasopressors? Because this will affect the blood flow, and so it reduces the absorption of the drug that is being given. And last but not least, we're going to look at these three. Oral antibiotics are not appropriate for all indications, and we've said that over and over again. And the lack of a functioning immune system that interferes with the assessment of clinical improvement should also be considered. Microbiology cultures have not had enough time to incubate. So yes, we want to reduce the cost on the facility, the institution, but we're not getting the results. Wait until the results have come. And that takes us to the end of the presentation for today. And those are the references. Any questions? Okay.
I just want to thank Dr. Royal. I know you have some burning questions, but I want you to stay put, make note of your questions. You can also type them in the chat. They will be addressed shortly. But of course, we want for you to capitalize on the few minutes that we have, and we will be going into the next presentation. But one of the new norms that we are now practicing is that of having our meetings and our presenters in various different places. So I could have had a presenter from Guyana, but she decides to be in Jamaica. Our next presenter is Dr. Sheree Bentic, and she's going to tell us about managing our headaches and this COVID-19 versus migraine. A little bit about Dr. Bentic. As I said, she could have been in Guyana where she was born, but she migrated to Jamaica for work and study. She studied at the University of Guyana first, and where she did her bachelor, her MBBS, and completed in 2011. She pursued her medicine in Jamaica at the University of the West Indies, where she completed in 2019. She's currently teaching emergency medicine as an associate lecturer to medical students and postgraduate diploma candidates. She's the acting consultant in emergency medicine at the Spanish Town Hospital, where she enjoys doing art, sports, and family games. Kindly make welcome Dr. Sheree Bentic with Managing Our Headaches.
Thank you so much, Matron, for the introduction. And thank you so much for the organizers for inviting me to present on this topic today. It's very interesting, and especially with the changing tide of what we have to deal with. And as we've been told, our new normal, this is one of the interesting things that we can actually see in patients who present for management, either in primary care or in the emergency department, where we see them most often. So we're talking about migraine today and how it has changed or evolved during the COVID-19 pandemic. So let's begin. Slide, please. So migraines are a severe disabling neurovascular brain condition, and it's characterized by recurrent episodes of attacks of head pain that has no protective mechanism or no protective purpose. It's one of the primary headache disorders, meaning that it is just a headache disorder. It's not caused by anything else. It's actually just a disorder of the patient's makeup. And other primary headache types within this classification include tension type, trigeminal autonomic cephalgias, and headaches that may be associated with cough, exercise, sexual activity, even menstruation. Slide, please. So the burden of migraines within the entire population of the world, almost 3 billion people either have some form of headache, either migraine or tension type headaches, and that's a large group of persons, and they do present often for care. And one of the things about headaches is that it affects us in our peak activity year. So we would find that mostly young adults in the 15 to 49 age range, and more females than males are affected. Slide. And the lifestyle burden is also great. This is our lifestyle and new norms presentation webinar, and we find that the cost is staggering, in the billions of dollars. But then apart from the financial cost, there are also personal costs that the patient would endure, such as change in their quality of life, lost employment. And
Dr. Benji,
Dr. Rai James?
can you come a little closer to the mic? We're not hearing you so well.
Is this better?
A little. Maybe
How is
just
it
a little.
now? Are you hearing me well now?
Yeah, that's improved. Go ahead, Dr. Benji, as
Okay.
loudly as you can. Thank you.
I'm getting some feedback from another mic as well. So someone's mic is open. Okay. All right. So as I was saying before, the financial costs and even the personal toll that the patients would have to pay as a result of suffering from migraines. Sorry, I'm getting a lot of interference from Bell, Arelis, Bell.
What happened?
The mic is open. Thank you. Yes, that's better. So as we said before, the lifestyle burden is significant. Apart from the staggering financial costs to migraine sufferers and on the economy, the personal toll is also great, from loss of quality of life, productivity, and employment as well. Slide, please. So when you think about what we know from the epidemiology of migraines and what persons in there have been suffering, how have headaches affected you? Have you ever lost work or missed work because of a migraine? Have you been unable to participate in an activity? How many headache days do you actually suffer where you're in bed more than actually being out? Slide, please. So the pathophysiology of migraine is that slide again, press again. What they found is that some persons seem to be very vulnerable to developing migraines, and they call this a sensitive brain, and it may be inherited. They found that monozygotic twins more than dizygotic twins have a higher chance. If you have a relative, a first order relative, if your mother, your father suffer from migraines, you have a high chance of having migraines as well. And even abnormalities, and they found that there are some abnormalities in chromosomes that lead to either ion channel, dopamine receptor, or voltage gated calcium channel abnormalities that then predispose the patients to developing a migraine. Slide. So the activation is not completely understood. What we've been finding out now, because before it was previously classified as a primarily vascular condition, but now with continued studies and continued investigations of patients, it has transformed to becoming more of a neurovascular problem, where there seems to be some kind of nervous system stimulation that then leads to vascular changes and release of certain chemicals that then cause or trigger the migraine. And so it's either an abnormal activation of the trigeminal cervical afferents or abnormal modulation of the trigeminal cervical neurons. Slide, please. So there's some aberrant firing of neurons and cellular elements that get released that then lead to the combination of vascular changes. These may be vessels, large vessels, dural sinuses, and as well as activation of the nerves, particularly the trigeminal nerves, and the nociceptive components of the trigeminal neurons. And then subsequently, there is a perception of pain, which is then manifested as head pain that the patient feels. Slide. So in combination with studies that have been done, two neurosurgeons, Ray and Wolf, did experiments in the 1940s on patients who were awake during neurosurgery and found that these are certain areas that seem to be very sensitive for pain. And these may be the areas that are triggered that allows the person to actually feel pain and the severe pain that is manifested as a migraine. Slide. So the migraine has different phases. Not every patient has an aura. About 80% of patients have migraines without aura, but they tend to have a prodrome. The significance of the prodrome leading to the headache and how it can affect the patient has not been entirely linked, but some things and persons may recognize, sometimes you feel cravings, food cravings. You just have stiffness, you're yawning a lot. You might have trouble sleeping. And then subsequently you develop a headache. Now, whether we think that it's probably that you haven't been sleeping well or you had some food that led to the headache, we may actually start to now look at the things that happen before we develop a headache. Is this the prodrome that tells us that the headache is coming on? So this usually occurs from a few hours to a few days before the headache starts. And then the headache, which is more of a pulsing, throbbing type of sensation on one side of the head mostly, may feel nauseous, may have some vomiting as well. But this lasts somewhere between 4 to 72 hours. That is if medication is not used. This is generally the time frame that these headaches can last for. Can you imagine 3 days of a headache? And that is actually what migraine sufferers feel sometimes, just days on end of headache. And then afterwards, they have the postdrome, where they either have a very deep, satisfying sleep after the pain has finally resolved. The pain may be triggered every now and again by movement or doing any kind of strenuous activity. And they feel happy. I mean, who wouldn't feel happy after you've had a headache for the last 3 days? You feel on top of the world. Slide. So what has happened now with the advent of the pandemic and COVID-19 being a factor for these patients? So there was a study done looking at the impact of COVID-19 on persons who struggle with migraines. And they had about 1,018 respondents. And what they found, and this is for patients, the majority of patients didn't actually contract COVID, but they suffered effects as well. And the effects that they suffered were actually related to being fearful that they might catch COVID. So their anxiety levels were increased, change in their pattern of activity. One of the things for migraine sufferers, they need consistency. So sudden changes in activity increases stress levels, which can then predispose them to developing a migraine attack. So consistency is very key for a migraine sufferer. And more than 50% of these correspondents had an increase in their migraines. And the reasons they gave, some of them didn't have access to their neurologist. They were afraid to go to the emergency room for fear of catching COVID. They were fearful to go and get their medications. They were worried about work. If they would get what about their financial security? So a lot of those things were triggered. There were a small amount of persons who actually said their migraines improved because they didn't have to be in traffic all the time, traversing every day to go to work. They actually felt better being at home in a space that they were comfortable with. And so that helped them. But the majority of the patients had an increase in their headache. Slide. And then other studies had shown that even persons who didn't have migraines but had other chronic diseases had declining mental health. And we're also seeing that mental health is something that we're looking at more when we're considering the 360 view of the patient, not just treating the condition that they have, but their mental health and their ability to manage the strain. Persons even found that the intense media coverage around COVID-19 and what was happening, the number of cases, that tend to stress them out and cause an increase in their migraines as well. Slide. And then what happened to patients who actually did catch COVID? So, Zowska Prosol they've noted that they had about 3 patients. These persons were diagnosed with migraines, suffered migraines for years, but never had an aura. An aura being they didn't have any visual disturbance, they didn't have any motor weakness, no hearing issues. some persons tend to have that visual changes, which would either be they would see spectra or they would lose vision. Persons would have ringing in the ears, and even hemiplegic migraine, where persons lose power, is an aura, and persons tend to have that before. But these three cases that they found unusual were that these patients were not diagnosed with migraine with aura. And as I said, 80% of persons just have migraines, don't have an aura. So what they noticed first is that they had these strange visions, strange things in their field of vision. And you'll see in the image on the right, one of the patients actually drew what they saw, what they were seeing and what they were experiencing. Yellow, green light, hypersensitivity, hearing strange things. And they thought it was, they found it unusual because they never had it. And then they had their severe migraine. But the migraine was out of keeping with their usual pain pattern. They sought help. When they did scans, everything was normal. So they just thought it was their migraine. But then the pin dropped. These patients subsequently developed muscle aches, fever, loss of smell in a few days after the headache had resolved and tested positive for COVID. So slide. So persons who have migraines can now present with new auras, and their case presentation actually show that this may be something to look out for patients who have chronic migraines. So in studying this, what we have found as we're trying to work out how COVID really affects the human body. It's a neurotropic virus. It seems to have a tendency to be within the nervous system, and 30 to 40% of postmortem cases were found to have the virus within the CSF and various parts of the CNS, and it wants to spread to the CNS, and it has ways of doing that from the bloodstream, infecting the endothelial cells on the blood-brain barrier, the blood-CSF barrier, going through the synaptic pathway of the nerves, and even infection of the leukocytes. So it has ways to get in there. And once it does, slide please. Once it does, it can give manifestations in even patients who have migraines. So most patients who develop COVID, although the variation is quite wide, between 10 to 70% of persons. So not everyone will have a headache, but what we have found is that most persons do complain as that as being the initial symptom. And it's usually bilateral, unlike the migraine presentation, which is unilateral, but it can have some similarities in that it's throbbing, pulsing, pressing. But the key difference is that this headache does not really resolve with the use of pain medication. And so that is something to think about and try to elicit from the patients when they present complaining of a headache. Slide. So the International Classification of Headache Disorders actually give us some guidance on viral type headaches, things that actually characterize viral type headaches. And this will actually help us to differentiate the type of headache that the patient may be presenting with and may lead us in a direction to think. And of course, if there are other things associated, that it may be a headache associated with a virus, not just COVID-19, because other viruses can cause headaches. And these persons have a diffuse headache. It's moderate to severe, but the key is that it varies with the course of the illness. It will improve as the patient gets better, or it will worsen as the patient progresses further into the illness. And there is an association with the other viral symptoms. However, what they've also found is that the same trigeminal vascular structures affected in patients who have migraines are also affected in patients who have COVID-19. And so they can present with a migraine. So we have to keep our ears open and eyes open for persons who are coming in with migraines, because they may have COVID as well. Slide. And But these patients need to be evaluated thoroughly, especially if they're saying that it's more severe and they're having new features to their migraine that they didn't have before. And in addition to looking for causes of a virus or things that will cause a viral headache, depending on what type of aura, if it's a motor aura, visual aura, auditory aura, or any other sensory aura, we have to investigate the patient to make sure that they don't have something else that's just as serious that we may miss, such as a TIA, such as a carotid dissection as well. Slide. So in managing patients, what we have to try and remember how we diagnose migraines. And the International Classification for Headache Disorders gives us very clear criteria. And it's been mentioned before throughout the course of the presentation. It's usually, these headache attacks last anywhere between 4 to 3 days. And they also fulfill other criteria, such as the unilateral location, pulsing quality, but no, they may not have all of these criteria, and they don't need all for you to diagnose that they have migraines. They may also have nausea and vomiting, or nausea or vomiting. They may also have sensitivity to light and smell as well. And it's not otherwise accounted by other headache classifications. The ICHD-3 criteria are available, they're free online. So you can have a look and see all. It can be overwhelming, but take it in small bits. And it's a great reference guide to assist you with patients. Slide. And of course, these are the classification features for aura as well. Slide. So our tenets of treatment for patients, most of the times when they present to the emergency room, the headache is always already in play. And what we're trying to do is abort the headaches. And there are a lot of drugs that are available to us. Simple treatments like NSAIDs, Panadols, the triptans also help. And they help with their serotonin agonists, and they help with proper secretion of serotonin to ease these persons' headaches. Antiemetics can also be used as a standalone. And please forgive the typo, it's actually CGRP, which is calcitonin gene related peptide. That was a typographical error, my apologies. Opioids and barbiturates are a last resort though. Opioids and barbiturates have been found to cause what they call medication overuse headaches. And if you can stay away from them, try to stay away from them as far as possible for patients, because they can worsen the headache and work against you. Slide. But for persons, and then once we're able to help the patients with their headaches, one of the things we need to also investigate is, are they candidates for preventive medications as well? Because preventive medications can actually abate the number of headaches that these persons may have. And certain questions can be asked: the frequency of their headaches, how often they're getting it. Is it that they're using abortive medications very often? So are they at risk for drug overuse headaches? Is it affecting their quality of life? They can't go to work, they can't participate in their daily activities. These may be persons who are candidates for preventive care. Slide. And these are some of the options that we have, and they act on the various arms of what may be causing the headache, either the release of the peptides, the trigeminal cervical arm to modulate the nerves and their triggering and the sensation of pain. So it actually blunts the nociceptive pathway. And so these can actually be helpful. Botulinum toxin has also been explored and is actually a current arm of treatment, but it's not for the weak. These patients need to get 31, a significant amount of injections at one sitting every 3 months. I mean, if it is that you can afford it and you can take 30 something plus injections, it's also a treatment arm that has been used. and for persons who don't want to take medications very often. Slide. And of course, lifestyle counseling is something that the patients need. Migraine sufferers need consistency. So we need to counsel them on ways to ensure consistency. Need to tell them about food triggers like certain cheeses, caffeine. Those things can also trigger headaches as well. Sorry, can you go back? And ways to manage stress, how you can reduce the amount of stress that you have and that you're dealing with. And this can actually help to blunt the triggers, as well as trying supplements. Magnesium has been linked, and magnesium deficiency has been linked as a trigger for migraine. And sometimes taking supplements such as magnesium, CoQ10 can also help. And when all of these fail, seek help early. Don't overuse the medications because they lead you down a rabbit hole of pain. And get the counseling, get the guidance so that you can continue to enjoy your peak years. So thank you very much for listening. We'll take your questions at the end. So thank you very much.
Thank you very much. Not just thank you, but I'm sorry for that breaking transmission. I want to just thank Dr. Bentic for that presentation. I am sure many of us could relate to that, not just for our patients, but also for ourselves. And while we look at the change in lifestyle, I see our next presenter waiting. I just want to ensure that you're all relaxed, ready to go, even if you're having a headache. One of the lifestyle changes we have is that of this new norm of the Wi-Fi and all of that. But I just want to tell you that you must be careful how you use the Wi-Fi, because Mr. Richard next door had been riddled with guilt for a few months, and I've been trying to get the courage to tell his neighbor face to face that when he's not around, he's been sharing his wife day and night. You heard that? Sharing his wife. And he said it was probably much more than Richard was using her, the wife. I haven't been getting it at home recently. I know that's no excuse. The temptation was just too great. I can't live with the guilt and hope you will accept my sincere apology and forgive me. Please suggest a fee for usage and I'll pay you, Richard. Max was feeling enraged and betrayed. He grabbed his gun, went next door and shot Richard dead. He returned home and shot his wife, poured himself a stiff drink and sat down on the sofa. Max then looked at his phone and discovered a second text message from Richard. And the second text message read, "Hi Max, Richard here again. Sorry about the typo in my last text. I assume you figured out and noticed that the Dan spell check had changed Wi-Fi to wife. Huh. That will be the death of us all. So 2 people were dead just because of technology. We will now be going into our next presentation because I see our presenter ready and waiting. But before we go, I will ask Dr. Patterson to introduce Dr. Simone Dundas, who will be telling us how to reclaim our time during our busy schedule and during this pandemic.
Good afternoon, everyone. Today we have Dr. Simone Dundas-Biles with us, who is a consultant pediatric surgeon at the University Hospital of the West Indies, Mona. She also is a pediatric surgeon at the Ruthven Medical Center and Villa Medical Center in Mandeville. She's also an associate lecturer at the Department of Surgery, Radiology, and Anesthesia at the University Hospital of the West Indies. And she's also a PALS training facilitator at the Heart Foundation of Jamaica. With all of this, Dr. Dundas-Biles also has professional association with the American Pediatric Surgical Association. She's also a fellow at the American College of Surgeons, a fellow of the Caribbean College of Surgeons, and she has also served as a past treasurer at both Association of Surgeons in Jamaica and the Pediatric Association of Jamaica. Well, Dr. Dundas-Biles has also been a past president of her Junior Doctors Association and also of Medical Association of Jamaica. Now, Dr. Dundas-Biles has received her training at the University Hospital of the West Indies, where she obtained her BSc with honors in biochemistry, her MBBS as well as her DM in pediatrics. She further went on to be a certified provider of American Heart Association in both BLS, ACLS, and of course, PALS. Dr. Dundas-Biles, with all of this, also has research interests in improving the quality of pediatric resuscitation and the management of intersex abnormalities. Dr. Dundas-Biles also manages to maintain a healthy marriage and has 3 wonderful children. We now welcome Dr. Dundas-Biles to impart her knowledge and to share with us on the strategic time management for busy medics, reclaiming our time. Welcome, Dr. Dundas-Biles.
Thank you very much, Dr. Beckford. Are you seeing my screen and my little mouse moving on it?
Yes, we're seeing your screen.
And you can hear me. Great.
Yes.
Pray for my Wi-Fi, would you? Okay. Thank you very much for inviting
Dr. Dundas-Biles, would you like to be able to share screen?
Yes, my screen says that I'm sharing. Am I not sharing?
Okay, all right.
My screen says that I'm screen sharing. Are you seeing my screen?
Yes, you are sharing.
Okay, so can I go ahead? Hello, anyone hearing?
Go ahead, Dr. Biles.
Okay, great. Right. Thank you for inviting me, Dr. Wright James, to speak on this topic, reclaiming our time, strategic time management for busy medics. I was a little apprehensive when I first got the topic, but I can say that I have come a long way and learned a lot myself in the preparation of this talk.
Wait.
Let's see if I can. Oops. So, who am I? I fill a lot of roles and I wear a lot of hats. I'm a specialist surgeon with a full-time hospital public practice, 2 private practice locations, a teacher, a mentor. I do undergraduate teaching, postgraduate training, advanced life support training. I, to one degree or another, do academic writing, publications, fill leadership positions. I'm an employer, a wife, a mother, a grandmother, daughter of aging parents, a community organizer, and a student. Right now I'm trying to learn sign language, Jamaican Sign Language. So it can become a bit much. And to be quite frank, sometimes it is too much and it becomes a bit chaotic. It's very difficult to juggle all those balls and not have them drop to the ground like this Jenga game beside me. Many physicians and nurses and others in the health profession experience difficulty juggling their many roles that they play. There are more patients coming into the health system without more people being employed to take care of them. There are more complex patients, especially if you work at a type B or a type A hospital where people are referred with complex problems. Now we have the overlaying of COVID-19, which is a condition that can cause greater complications in what used to be routine cases. There are fewer resources for patient care and almost no resources for academic research. There's more administrative paperwork the more senior you get. And on top of that, we as medical professionals, I can certainly say for physicians, are much more easily accessible. I still remember having my Comtech pager where they called me and I call back when I get to sit down and be still. Now they email me and it's pushed immediately to my phone. I have a mobile phone that they can call me on directly, both patients and hospital. They can get me immediately and know if I've read their message on WhatsApp, and there's Zoom. So here we are in what at some times of the day might be considered personal time, family time, and you're sitting at home in a Zoom meeting. So you're much more accessible. There's a high rate of professional burnout. Many papers have been written about it and it's gotten worse since the pandemic. There are high rates of depression and suicide amongst physicians, and many of us face challenges with time management. So what are the natural consequences of poor time management? Well, research has shown there's poor clinical productivity, there's lack of success as an administrator and as a teacher, missed deadlines, slow growth in institutions or practices. One can be overlooked for promotions because people perceive you as just not coping. There's diminished job satisfaction, and it has an adverse impact on the personal life. There's burnout, higher rates of stress, anxiety, depression, and an increased suicide risk. And many of us have seen pictures like this doctor pictured here of COVID wards all over the world, the exhaustion. So what really is time management? It's a buzzword these days, time management. What it really means is how to avoid chaos and your whole house of cards coming toppling down and still get things done. Literally, it's the process of planning and exercising conscious control of time spent on specific activities to increase effectiveness, efficiency, and productivity. Another buzzword that goes hand in hand with better time management is the work-life balance. Work-life balance is the term that is now used for the equilibrium between your personal life and your career work. The balance, not the imbalance, the balance. The division of one's time and focus between working and family time or leisure time is what is work-life balance. And simply put, better time management leads to better work-life balance. So Gordon and Horton have actually put together 4 simple time management strategies, which I have found in my reading are simple enough to follow and worthwhile trying to implement. They are setting short and long-term goals, setting your priorities amongst competing responsibilities, 3, planning and organizing activities, and 4, minimizing time wasters. So let's talk a little about setting short and long-term goals. It's important to frequently set and revise goals. You don't just set them on graduation and put them down there for the next 30 years. Frequently set and frequently revise goals. Short-term goals usually refer to things that you expect to accomplish within a year or 2 or 3, and long-term would be along about 5 to 10 year time frame. Don't let long-term goals be dominated by immediate, urgent, short-term goals. And that is the temptation, because the immediate and the urgent is right in your face and demanding your attention. Instead, identify and protect the time required to set and accomplish these long-term goals. because it is the long-term goals that bring satisfaction and a feeling of progress, especially in your career. Review the goals frequently, see what you need to adjust, and it's helpful to do periodic progress reviews with a trusted mentor or colleague. So although I'm giving a list of things to do, I need to say my disclaimer here. Nothing about this means that I have mastered these things. I have made almost every misstep that I am about to talk about. It's not coming from any position of mastery or perfection. It's a work in progress. So let's talk further about setting short and long-term goals. So it's important to do an honest reality testing of your goals. Is this a reasonable goal to set? Are my goals achievable based on the skills I have now and my current professional standing? So if I want to be Simone Biles, the gymnast, and win an Olympic gold medal, is that a reasonable thing for me in my unfit middle-aged state to want? Can I start by saying I want to take beginner's gymnastics class? That is a realistic goal, and based on that, I can set further goals. It's important to avoid setting unrealistic or conflicting goals because these lead to frustration when they're impossible to achieve. Also, on the other hand, avoid setting overly conservative, lackluster, think goals, which lead to stagnation, waste of your talent, and dissatisfaction. So always pitch it a bit higher than where you are now. Select specific intermediate milestones. So vague long-term goals need to be brought down into intermediate milestones that you can have some successes along that 5 to 10 year journey. For example, if I want to improve, I want better professional growth. That's kind of vague and long-term, but if I say I want professional growth as a university academic, then I start to ask questions like, how many lectures per year do I need to do? How many papers do I need to publish per year? What's my student contact time that I need to fulfill? What's my clinical time that I would need to fulfill? And by achieving these intermediate goals, I eventually reach the bigger goal of professional growth. Review and repeat the reality testing of your goals periodically. Are you on track? Is the pace on track to reach to the goal that you have set in the time frame you have set, or do you need to pick up the pace? Also, do external demands necessitate revision of your goals? The obvious elephant in the room would be the COVID-19 pandemic. That has caused many people to have to adjust the timelines on their goals or even how they achieve their goals. I might plan to give 10 lectures in 3 months, and then I realized that I have to learn how to work Zoom and OUR VLE at the university in order to deliver what I want to deliver. And classes might be suspended for 3 months, 4 months at the university because of the pandemic, and we have to adjust our goals accordingly. Number 2, setting priorities amongst competing interests. So we all have our existing responsibilities, and for sure, every so often, and for some of us every day, someone will come to you with an additional task that they would like you to do, or an additional responsibility that they see you as the perfect person to take on. You, as the person who's making the decision, need to determine whether this new activity or responsibility will advance or retard your progress towards your short and long-term goals. That is actually a decision you have to explicitly make. Decide whether it will be a yes or a no, but thank you for considering me for this opportunity. But it is a decision. It's not a passive process that says because they've come to you with it, you must drop what you're doing and do it. That is what leads to chaos, which we're trying to avoid. If you're unable to decline, because sometimes the person asking you to take on this new responsibility may be your boss, decide what it is you must give up in order to accept the new task, because something will have to give. You cannot do 2 things at the same time. So you may have to give up something, or you can negotiate to accept this new task or responsibility temporarily for a limited time and then get back to your program, or you can negotiate to delay the beginning date of this new responsibility. So we want to avoid reflexive acceptance of tasks, especially if they're clearly antagonistic to your central goals. All new responsibilities, new tasks need to fit in with your goals. Recognize and declare it when something is not important and not urgent to your work and your goals, and find a way to say no. As I said, sometimes it's unavoidable, but most time you can negotiate it so it is not so antagonistic to your goals.
Dr. Biles,
Yes, Anita.
Dr. Biles, just a little notch up, a few notches up with the audio. It's a bit low. It's getting a little low. Thank you so
Sorry.
much. Thank you very much.
Better now?
Yes, as loud, whatever, as loud as close as you can and as loud as you can. Thank you.
All right, that's my maximum. I'm going to shout. Can you hear me?
Very good. Thank you, Dr. Biles.
Okay. So setting priorities amongst competing interests. What are your existing responsibilities and where do they fit in? Many of us have seen some version of this chart in various sources. This is Kobe's chart from the 7 Habits of Highly Effective People. And it has 2 columns, important, less important, and urgent and less urgent. So there's some things that are important and urgent. For example, a patient who presents with chest pain, or a presentation at an international conference in 3 days' time. There are things that are important and that are not urgent. And those would include maybe to plan a clinical quality improvement initiative or review your long-term career goals. Believe it or not, in this quadrant, quadrant 2 is where the satisfaction in your job and the feelings of achievement usually arise. But we seldom make time for these things. The less important, I want to say not important things, but less important, but urgent things would include patient phone calls, billing of patients before they leave hospital. And the things that are less urgent and less important would include non-urgent letters and routine paperwork and routine committee meetings, because it's been 3 months since they last met. So all the tasks that you have to do an accurate and honest placement of your activities into these quadrants. Spend the time, and it will help you focus your attention and the allocation of time on the important activities, which are the ones in this quadrant 2. They're important, but they're not urgent, and they will fall by the wayside if you're not deliberate about nourishing them. The time spent on important, non-urgent tasks in quadrant 2 are the ones that promote long-term achievement and require larger blocks of time. The important urgent tasks are quadrant 1. Those are the ones that usually have an up and coming deadline right now, and they cause a lot of stress and exhaustion. If you spend all your time doing the urgent, important things, you will have a perception of your job as a perpetual struggling to catch up, always in the rat race, and most likely without great satisfaction. Productive physicians are those who increase the time spent on the quadrant 2 activities. Those are the long-term, important, but not urgent things. Progress on quadrant 2 requires scheduling, because they're not going to be screaming for your attention. You will have to schedule them. For example, a weekly time for academic or publication writing. And the other things that are not in quadrants 1 and quadrants 2, the ones that are not in the important column, delegate it without guilt. There is someone who will consider it a great opportunity to show what they can do to do the things that you are dreading doing and bogged down doing. Number 3, planning and organizing activities. That is finding time for important long-term activities so that you can effectively complete your key tasks. The advanced planning is needed. It's not a reactionary planning. So you can't plan to revise the whole clinical curriculum for the postgraduate program for your specialty, let's say pediatrics, or in my case, pediatric surgery. You can't do that and just wake up one morning and say, oh yeah, that's the most pressing thing to do now. You have to plan when you're going to make that big time to be creative about it. A weekly or monthly schedule is what you'll use to plan this, not a daily schedule. It's not a wake up in the morning and just braps and do it thing in most cases. And you should know yourself to know your most productive times. Some of us, like myself, are early risers and are productive at that time, and others are night owls and don't ask them to do anything in the early morning. Know yourself. How much time is necessary? Reserve that time and limit the interruptions during that time. Close your door, mute your phone, use the best time for these important achievement goals. Use your high energy, high creativity time. If you find you can't make a big block of time to do it, break it into small bites, 30 minutes a day for a number of days until you have gotten it started. Because sometimes just not having the amount of time you need stops us from ever doing it at all. I have some things in my inbox for over a year because they're important and I've just been daunted by doing it. Today, I'm going to find 30 little minutes to put on it. Catch up with your phone calls and your emails outside of this time. I know that when you start looking for the files to do your big tasks, it's easy to be distracted by all the new emails in your inbox. Don't use that time, your achievement time, your long-term goals time, to do your phone calls and emails. When you have settled on a time, select an optimal venue. That might be somewhere traditional like a library, or it might be a cafe, wherever you can be not interrupted and have your good Wi-Fi going and that you can concentrate. How do you plan and organize activities? It requires organizational skill, yes, but more than that, an awareness of your calendar. Group similar activities together, such as meetings. So if you group them, if you know that Thursday is your busy day, don't schedule the big tasks on a Thursday. Group the meetings together, and then you will find that you're able to free up larger blocks of time for your important long-term activities. Reserve blocks of time each week for your quadrant 2 activities. Prepare for them before the time when you arrive at work, on the commute maybe, or when you are packing the night before, so that when you arrive at work, boom, you hit the task, run it, and it gets done. Number 4, minimizing time wasters. These are interruptions, distractions, or other delays that reduce productive time. They may be physical interruptions, technological interruptions, or hidden time that we are going to reclaim, like Miss Auntie Maxine in the Congress, huh? So in the reference that I had given you, the article by Gordon et al., they mentioned 10 common time wasters and potential solutions. I'll give you the reference for the whole article, but I'm just going to list them and just speak a little more about 3. Telephone calls, emails, physical interruptions, paper, just piles and piles of paperwork that just keeps coming in to be sorted, repetitive activities, disorganization, procrastination, can I get an amen? Meetings, waiting for meetings, commuting, all of those are 10 common time wasters. So let's talk a little more about minimizing physical interruptions. In an office setting or a hospital setting, a clinic setting, physical interruptions are common. It might be visitors who come to your office or your area of work, or it might be visitors who actually need your help. So not only do they want you to stop what you have scheduled yourself to do, but they would like to replace your agenda with their current agenda that they need help with. It's useful if you are doing something important to close your door if you have a door while focusing. Go somewhere where you won't be interrupted. Emerge or open back your door when you are done. That way, I mean, I'm not proposing that you lock your door all day. We're talking about maximum of 90 minutes at a time. and you focus and do your task, and then you open it, and they'll understand that you're approachable when the door is open. Minimize technological interruptions, emails, calls, WhatsApp, Facebook, Instagram. Limit yourself to accessing your email and responding to them 3 to 4 times a day. Avoid back and forth immediate emails. This is actually improper use or abuse of email, where it flows like a conversation, and before you look at, you have 9 emails back and forth with the person, and you've had 9 interruptions of your supposedly important task. Disable audible alerts. Respond in the brief periods between meetings, unless it's your job, like your telephone operator, and it is your job to answer the phone and respond to messages. If you're a receptionist, then you have to respond immediately to the messages. Set your email to automatically delete spam so that you don't have to read it, search through it, delete it, and try to prevent the next one. Set it up to automatically happen. Discard unnecessary emails and paperwork. There's some HR professionals who recommend that you handle paper or email only once. So once you're ready to give it your attention, you look at it and you deal with it, you respond to it, or you discard it. But picking it up 4 times, putting it down, saying, I can't deal with it right now, can't deal with it right now, is just interrupting yourself more. Forward your phone calls during the time when you're achieving your important tasks to a trusted administrator or receptionist who can take a message for you. Reclaiming hidden time. Carry your paperwork or day planner to complete while waiting for meetings. You can read a paper, edit a paper, review slides while on public transportation, listen to CME recordings while driving, or listen to something relaxing, an audio book, music while commuting, which promotes innovative thinking. There are several myths about time management that I would like to briefly speak to. One, the myth that being busy is the same as being productive. I'm a very busy person. I'm not always a productive person. Being busy is not the same as being productive or effective. One needs to focus on the results, not the hours that you're putting in. So good time management requires a shift in focus from activities towards results. So it's not how much you've done to achieve it, it's whether or not you've achieved it. Multitasking is a myth also. Multitasking, your brain can really only do one thing at a time, the research shows. And switching between tasks costs you time, leads to cognitive fatigue, and increases errors. So when you're multitasking, you're actually switching from this task to that task and back again, and back to the other one again every few minutes. Spending your day in a frenzy of activity often achieves less because the attention is divided. So you want to try to minimize multitasking. I used to love multitasking, but I recognize it's not as productive as I thought. Myth 2, that we can get it all done. Recognize that you, like me, we're limited resources. Spend the time to truly evaluate your goals. Align your time management with your goals and accept that you're not going to get it all done. Therefore, you have to make explicit choices about what you're going to do. Not a passive, oh, whatever, screaming at me is what I'm going to do, but decide what you're going to do. Identify the right things and do them. Your activities, if you write down all your job activities, can usually be grouped in order to facilitate better analysis. We're talking about these are 6 categories here. You might group them differently. Your core responsibilities, which would include things like, for me, doing ward rounds, doing surgical operations, personal growth, things that are valuable and meaningful to me, but not necessarily related directly to my job and not every day, like mentoring junior colleagues, managing people, giving reports to people, crises and putting out fires when your patient crashes and they have to get admitted to intensive care unit, free time, personal emails, surfing the internet, posting on Facebook, and administrative tasks, doing the monthly reports. Track the time that you spend on various tasks each week. Then realign your time allocation with your goals. Myth 3, if I had more time, I would be more productive. The truth is that we all have the same amount of time. 24 hours a day, 7 days a week, 168 hours a week. That's a lot of time. How are you spending your 168 hours a week? If you have a 40-hour work week, and truthfully, few of us in the health sector, in the public health sector do, and you sleep in 8 hours a night, I know it's plenty. That's 56 hours. That still leaves 72 hours for you to allocate to family, friends, or other important tasks. That works out to more than 10 hours a day for you to allocate as you see fit. If you have a 50-hour work week, it still gives you 8 to 9 hours for you to allocate as you see fit. Many professionals incorrectly estimate their own working hours, but you will appreciate that the longer your work week, the fewer hours you will have, but it's still quite a bit of time that is still discretional. Myth 4, I never see my children or spouse because I'm always working. Research amongst American women has shown that they spend more time with their children than women did in the 1960s. Maybe more things are automated now or outsourced. And it's understandable that you feel you don't have time when you're attending purely to urgent things. Although you do have time, you have the same time as everyone else. You feel time is scarce, and scarcity focuses the mind on immediate challenges and urgent needs, like patient care, meetings that are right now, Zoom meetings. However, the important things that are peripheral and not screaming loudly get ignored. Sometimes that's family or long-term goals. First step is to acknowledge that you do have the time. Empower yourself to prioritize your goals. If it is that family is the most important thing, then they need to get in the center of your attention. Schedule the time to dedicate to your long-term goals and fiercely protect this time. Feeling overwhelmed, it's a feeling that all of us experience at some time or the other. It's caused by not having control of your circumstances, no predictability at the workplace, anxiety. The cure for that is really to change the way you manage your work. Take it in hand. Define your mission. Sit down with your boss, set clear parameters and performance measures. Many of us go to work and do everything that is required of us in terms of what is there to do that day, but very few of us know our job descriptions or what our performance is being measured against. It's important to communicate and adjust. Communicate with your boss and adjust accordingly. Understand what's being measured and valued at the workplace. Make your to-do list. First of all, schedule the activities that work towards your goals and priorities. Then with the time that's left, you schedule the other things. Remember, most of your to-do list will not get done. The sooner we realize that, the better. Hire out the small chores. You also have to probably revise or eliminate culture and gender biased ideas like the woman is responsible for all of the cooking and all of the cleaning in the house, for example. The sooner that type of idea goes, the more productive everyone will be. Do what is best for you to work and have your family life. Don't feel guilty. Use your healthcare team. They want to be trusted and given responsibilities. Allow them to grow by trying to do new things. Delegate exhausting everyday micro decisions and save your energy for the decisions that matter. On the subject of feeling overwhelmed, embrace the restorative power of vacations. Take your vacation leave. Your vacation leave is your time. You have earned it. Nobody's giving it to you. You have earned it by the days you have worked. Take it, use it all up. I'm not good at that. I'm preaching to myself also. But at the end of it, each time you do, you will feel better. You will work more efficiently and you will have better personal relationships. In conclusion, the increasing pressure on medical professionals demands effective time management in these times. Improving time management increases physician productivity, enhances career satisfaction because you're focusing on your achievements in your career, and improves the work-life balance. Time is the coin or the currency of your life, said Carl Sandburg. You spend it. Do not allow others to spend it for you. Thank you very much to Dr. Wright James for helpful references and for inviting me to give this talk. These are my references. If you can only look at one, I highly recommend this article by Gordon and Borkan. It summarizes in a very practical way how to implement effective time management, and it's only a few pages long. Thank you very much.
Can you
Dr.
provide a
Dundas,
reference?
I just need to cut in, Dr. Wright James, and give you my special kudos, my special thanks. I mean, I think no better person to have done this presentation. Very great. I got a lot of pointers for my personal self. And just to tell you how Dr. Dundas does manages time so well. I think I gave you what, less than 2 weeks? And what an awesome presentation this was. So I just wanted to make my special thank you. So thank you very much, Dr. Dundas. We have been empowered, and I like the vacation part. Thank you so much. Let me hand over to the moderator. Thanks, Dr. Barnes.
Thank you, Dr. Dundas. Who better could have done a presentation on time management than the presenter who did it in the nick of time, not a second over. That was very great. You had us on the edge of our chairs because it's so practical. We really should have this as a workshop because we have our little inputs too, because when we look at even the time wasters, I'm telling you, I don't go into all those areas that you mentioned. I just go to one. And just to send out WhatsApp in the morning, I've gone like half an hour and I have to say, I have to stop now. And I'm sure that a lot of us have been caught up in that web. And the procrastination story, oh my Lord, don't we all know that there's a payback for that sin? Thank you again, Dr. Dundas. At the end, though, you already received the thank you, but you will be getting more. We will just now go into some of the questions that have been placed in the chat, but I want, as we do so as well, to remind remind the persons just to fill out the questionnaire that has been placed, that has been posted. They've been a good audience so far. And we are now going to have Drs. Smith and Clark, who will be guiding us through the question and answers.
All right, good afternoon, everyone. Sorry about that. Good afternoon, everyone. I hope you guys learned a lot from the presentation just given. So we have a few questions for our presenters. Please turn off your mics. Please mute. Presenters, I'm going to ask that you please turn on your mics. And your cameras, if possible. The first questions go out to Dr. Josette Morrison on her presentation about making a switch, IV versus oral. So the first question is, is everyone hearing me?
Yes.
All right, so the first question is the first question for Dr. Josette Morrison is, what are the suggestions?
What are the suggestions?
Is everyone hearing me?
Yes, I'm hearing you.
Okay, and I'm seeing that now.
Apologies for the technical difficulties. The first question for Dr. Josette Morrison, what are the suggestions reconverting from IV to oral medications for neonatal patients, and are there different policies depending on the age of such a patient?
Yes, there
Dr.
are.
Morrison?
Yes, are you hearing me?
Yes, we're hearing you.
Okay, wonderful. There are different policies regarding pediatric patients. And what I found in my research was that it was more institutional based. So there was no standard, because some persons would have said that you do not recommend switching in children under 12, but then there were other pediatric guidelines that were found for particular medications which varied based on the patient's age. So it will have to be done on an institutional basis to determine the best fit. Dr. Patterson? Dr. Patterson?
The second question for Dr. Morrison reads as follows. Is the Pharmacy Association looking to formulate drugs that can be given via NG tubes? The reason why the person had asked the question is because they say that there are a lot of issues relating to the current available medications, re-giving it via NG tubes.
Well, it is not through the Pharmacy Association that these formulations would have been done. It's through the manufacturing companies that they would have made the different ones. But at different levels, we do engage in compounding of formulations, whether tablets or capsules, into suspensions, most likely liquid formulations, to allow administration via NG tubes. But this would not be through the Pharmacy Association. This would be through the manufacturing companies. So in the US, for example, and other international countries, you'll find that those are more readily available than it is in third world countries.
All right, thank you very much for that answer.
You're welcome.
Thank you very much for your answer, Dr. Joseph Morrison. We're going to move on to questions for Dr. Sheree Bentic at this point.
Good afternoon. Dr. Bentic, are you hearing us?
Yes, I can hear.
All right, so the first question for you is, how can you differentiate between a headache with a sinister underlying cause versus an everyday headache for persons with migraines?
Okay, so, well, I'll answer that question in two ways. Well, persons who have migraines, and specifically any change, any developing aura for those patients, persons who are having worse than usual headache, those persons, that would be considered something that you should investigate. Of course, the patient never had an aura and all of a sudden they're having visual changes, loss of vision, and seeing other new signs of aura, you have to actually investigate those persons to determine that it really is part of their migraine pattern and not that something else is now presenting for the first time, and they're also having a headache with it. Persons who generally have a headache that is the same kind of pattern that they have, they usually see a doctor, and they also have been previously diagnosed with migraines. Those types of features tend to be more reassuring. However, if it's a patient who's coming with a general headache, you're not quite sure if they have a primary headache history from before, don't neglect the importance of a history and a physical examination, because that will actually cover about 80 to 90% of the work that you have to do. Even if you don't know what type of headache it is and what's causing the headache, getting that type of information. So somebody who's telling you they're having a thunderclap headache, and they don't usually have headaches. So a headache that has gotten quite severe very rapidly, right? Persons who are having—
You don't know. You can search, right?
Hello? Somebody's mic is open. Yes, persons who are having new focal deficits. So they're having motor weakness. They're also complaining that their headache is worse when they're lying down or when they're coughing, to suggest that maybe they have raised intracranial pressure. Of course, these features can also be identified on a physical examination too. I know a lot of us don't like the CNS examination, but it offers so much information when you can do a proper CNS examination on a patient and you are able to identify that they have focal deficits. And of course, looking at the eyes, so persons who were complaining of vision changes, or they have a sudden red eye, painful red eye, that would actually suggest acute glaucoma, and it can come with headaches because of the raised intraocular pressure. So you also have to examine the patient's eyes as well. So some of these things, and of course, you do have to have a foundation of knowledge in terms of what actually characterizes a primary headache, and what features are associated with a secondary headache. Remember, as I said before, viruses can present with headache too.
So those are some of the things that you can use to assist you in determining whether a headache is sinister or if it's just a primary headache that the patient is having.
Okay.
Should I move on to the second question on my own, or?
You can, but it's for the audience.
Okay.
Has coffee been proven to have any effect on migraines or headaches? Is there any scientific proof towards that?
So it hasn't, in terms of the mechanism, that's not quite clear. There have been studies done, and coffee has an effect on migraines in two ways. So coffee can actually block adenosine receptors. So if somebody is an occasional coffee user, so they don't use coffee every single day, they don't need their dose of coffee in order to function. So you might use coffee maybe once a while, maybe once every couple of weeks. So it has actually been found to have a dampening effect if you have an occasional headache and you drink some coffee, because adenosine through some kind of unknown pathway can also have effects in triggering migraines. So coffee has been found to be able to suppress and block the receptors that are open for adenosine. Of course, if you take too much coffee, so you have coffee every day, you have one of those mugs that say, don't talk to me until I have my coffee. I know I have one of those. So that, remember, coffee is also a chemical and it's a drug. So if you take too much of it, eventually your body develops a tolerance. So there's a tachyphylaxis. And so the receptors become downgraded. So when you stop drinking coffee and your body is used to getting its coffee dose 3 times a day on the dot, then you suffer the symptoms of withdrawal. And you can also, and then similar symptoms of withdrawal include your fatigue, you're very cranky, you don't want anybody to speak to you, you're irritable, and you'll also get a headache as a result of the withdrawal symptoms that you feel. And of course, similar to medication overuse headaches that persons have, it can also cause headaches from being overused as well. So yes, coffee has both effects, and caffeine, which is a factor in coffee, has been added to certain medications. So there's a Panadol, acetaminophen, caffeine mix that some persons have, particularly for medications targeted for migraines. Caffeine has been found to help, but of course, and even patients who have migraines use a very low dose of caffeine, or they take coffee in low doses to try and help to prevent the onset of their headache. So it can work in both directions. So of course, moderation is always the key in anything, as always. All right.
Okay, final question for you, Dr. Bentic, from someone in the audience. If anybody comes in with having a severe headache, first time, do you suggest them being swabbed for COVID-19?
I think in our present state, if it may be something to consider. It's actually not a recommendation. There must be something else in the history that is suggestive. I mean, somebody presenting with a sole headache, it's not going to be one of the primary things at the top of my list to evaluate the patient, but it is something that we should always keep in mind. And therefore, the patient should be advised that if they do notice other symptoms, it may warrant them requiring a swab. Of course, persons can be swabbed even on request. So if it is that they have a concern, you can actually try to mount to the patient's request, but it's not something that I would do from a first presentation with headache. However, it is something to consider, and it's, of course, we do have our policies within the hospital that any patient who will require admission, so eventually if they are going to be admitted because of their headache, they will eventually be swabbed. But there may be more that I would need in the history and my physical examination to decide if a swab is necessary for the patient. as you know, the rules for COVID are dynamic and we're still learning and we're still evolving. So there is no one direction to go with this. And you can even use your clinical gestalt and make a decision for the patient as well.
All right, thank you, Dr. Bente.
You're welcome.
Final question is for Dr. Simone Dundas-Biles. Are you hearing me?
Yes, I am.
Okay, so a question from someone in the audience. What advice can you give to junior doctors relearning how to properly communicate with their seniors as it relates to having effective time management, effective and efficient time management?
Okay, good question. I think there'll always be some seniors that are more easy to communicate with and some that are more difficult to communicate with. And for sure, as you get more senior, you have more control over what the demands of your job are. I think though, at any stage of your career, the most important thing is for you yourself, whether you're a junior doctor or you're one of the seniors, to spend the time to decide what your goals and what your priorities are. I think very often people who are in a junior position expect the person in the senior position to organize them for them, organize the junior person for them, rather than the junior person taking personal responsibility for how their time is organized. At most of the time that you will be organizing may actually be your time away from your official duties. As I said, it's usually 8 to 10 hours a day that is discretionary, and you can decide how you spend that time. Once it is that you see a clear conflict between what you're doing or what you're being asked to do at your job and your goals, your long-term goals, you can take the time then to speak with a senior to explain what your goals are, not the long form, the short version of it, and ask if there's any way in which the duties or the activities can be adjusted. Most of the adjusting is going to happen within your discretionary time though. It's not going to be ward round time that you get to play tennis or to be with your family. Those things are kind of fixed. And it is the other hours of the day that you really have to reorganize and make sure that your priorities are dealt with in there. So I wouldn't think it is the senior's job to make the time for you in your schedule. You need to decide what are the hours that you really have in your schedule and start appropriating your important things within that, because the ward round is going to be at 8 o'clock or whatever time it is, same way. And be polite.
Okay, thank you. Final question for you, Dr. Dundas-Biles. What advice do you have for junior doctors who are on call covering multiple areas, multiple wards, and they're being called from each ward at the same time? What advice do you give in terms of them being able to carry out their tasks in an efficient, timely manner?
Okay, this is one of the times when you have to acknowledge that you really cannot be everywhere at the same time. And your clinical triaging rules would apply in terms of addressing the patient with the life-threatening complication or life-threatening problem first before the person who may have a non-urgent issue. And for example, I'll give an example. If there are 2 people who have come to the emergency room at the same time, and one has an asthma attack and is about to stop breathing and is turning blue, and the other one has a skin rash, but they came there first and they've been waiting for hours and they're vexed now, it still is the asthmatic that you need to go to. Basic triaging rules based on medical principles need to apply, and we need to explain or ask the other member of staff, the nurse, to explain that the basis on which that the triage is done, that it is not a first come, first serve thing. And if it is that you get to a situation too late, as sometimes happens when you're covering multiple areas of responsibility, you need to document. called at whatever time, arrived at whatever time plus 20 minutes because I was attending to an emergency on another ward. Write it down. Write it down.
Okay, thank you.
You're welcome.
At this time, we'll hand over to our moderator, Nurse Robinson.
Thank you, Dr. Smith and Clark. Well done. You can hear the babies in the making. And they did keep their time as well. They have learned so much from Dr. Dundas just now. And I've been doing well at timekeeping. I don't know if it's because I saw one of the presentation as time management. So I was about to lose the job, but I think based on how I'm doing so far, I will have the job next 2 months. I just want to remind you that the link is in the chat for the survey. Just to ensure that you fill out the survey. We are keeping time management, good time management. We have 4 minutes. If there's anyone with a burning question from the group and you want to ask a question, you can open your mic and go ahead while the others are filling out the survey. And we do have, remember that this is a free session. We just do all these free things from Spanish Town, and it's all because we have sponsors. They're moderate. That's my So while our sponsor is getting ready to present, is there any questions we're giving you? I hope you've been moving around where you are, even though the Minister of Health said that we're not to be moving. Remember, the same minister who told us a few months ago that one of the change in lifestyle, he did say we were to move, Jamaica must move. So when they're saying we're not to move, it's just outside of our gate. But once we're in our space, we can get up, move around, stretch, so that we don't end up with any lifestyle illnesses. Any questions in the group? Anyone want to open their mics? Okay, everyone seems to be relaxing. So I will now call on a representative from Novartis, and she's Shoshana White, and she is going to do a presentation for us. Please make welcome our sponsor from Novartis.
Yes, can you hear me? Hello? Can you hear me? Can you hear me now? Hi, good afternoon. Hi, good afternoon.
Shoshana Smith, are you there?
Yes.
Yes, I'm here, but not sure if you can hear me. Can you hear me? I can hear you. Can you hear me? Mic check, mic check. Yes, I can hear myself.
can you confirm that you can hear me?
Yes, we're hearing you.
Okay. I'm just getting that feedback now. Thank you so much. Okay, so I'm Shoshana White-Smith, medical representative with Novartis. And briefly, just wanted to share with you and thank you so much for inviting me to be a sponsor to your pediatric meeting today. I sincerely appreciate it. I cover the portfolio, the pain portfolio with Novartis, and that includes Cataflam and Voltaren. Right? But for our pediatric population, I'm more zeroing in on Cataflam because that is where we have our approved indications for, and we do have our presentations to suit your many patients that you have coming in. So with Cataflam, yes, with your patients that coming in, you'll see your patients coming in with their pain, their fever, and inflammatory cases. And I'm sure you want to get them from being agitated to, of course, having smiles, and that's how you want to leave them. And with Cataflam, potent pain relief, you can certainly do that together. There's no pain, more people suffer from pain than from hypertension.
Sorry, Mrs. Smith,
Yes.
can you speak up a little louder, please? The audio is a little low. Thank you.
Okay, more people suffer from pain. Is this any better?
Yes, much better.
Okay. Than from hypertension and cancer. And just confirming, are you able to see the slide change? Yes? Okay, okay, all right. All right, I'll continue. Right, we do have approved indications for your patients coming with any ear, neck, and throat infections, for your post-traumatic pain, such as your sprains, your fractures, and your post-operative pain as well, and also for painful operative conditions, your inflammatory conditions, so for your older children, preteens, for your dysmenorrhea, and even for your migraine cases. Cataflam will achieve Tmax within 20 minutes in comparison to the other molecules that you have to choose from that are readily available. We do achieve our Tmax, and some molecules can take up to 4 to 5 hours. Right, and how is this done? This is done by our additional mechanism of actions, where we inhibit cyclooxygenase 1 and 2, and that allows us to give a better efficacy and safety profile. But we also have mechanism of actions as it relates to the brain, the spinal cord, and the neurons. And with the brain, it inhibits the pain at the different levels as it relates to the spinal cord, where it blocks the transmission of pain, so you will not get that hyperpolarization to cause that action potential. And as such, all your pain inflammatory mediators would be inhibited. Also, we increase your endorphin levels, so you not only will get that pain relief, but you'll also feel good by having your pain being relieved. Now, this is showing our emerging mechanism of action at the cellular level, the tissue level, where once you have tissue damage, you will have the propagation of the arachidonic cascade, which will, of course, your inflammatory mediators being propagated, and from there lead to your pain, your inflammation, and your fever. And you're seeing where cataflam or diclofenac molecule goes ahead and binds to the different receptors, and of course, diminishes the pain. Now, just a study quickly want to share with you how quickly we act in comparison to two other molecules, paracetamol and dipyrone, where you can see you have over 122 children being treated with temperatures over 38 degrees, and these children, my apologies, these children are either given cataflam, paracetamol, or dipyrone. And showing from that cheetah print, it shows that we not only reduced the temperature, but we also kept the temperature low for an extended time. So it should have faster and efficacy as it relates to reducing fever. This just shows here efficacy in treating other molecules. So not limiting it just to the pediatric population, but of course you may see children, older, may see young adults who may come in with their different areas of pain, and you may need other molecules or tend to prescribe other molecules. They're showing you in comparison to etoricoxib, which is a COX-2 selective inhibitor at their maximum dose of 120 milligrams, that we are indeed comparable at our intermediary dose of 100 milligrams in terms of the number of patients needed to treat. That's the NNT, where you get at least 50% pain relief with the first dose within 4 to 6 hours. As it relates to our cardiovascular and gastrointestinal risk factors, we are neither too much COX-1 selective or too COX-2 selective. We're stuck in the middle, and that allows us to have a better safety profile in comparison to the other molecules that you have to choose from. Now, in the pediatric population, just another study to share with you briefly, that you had over 5,000. This was a multi-centered study which was done, treating over 5,400 children, and they were given cataflam drops, right? And it showed from here that 94% of the pediatric population had no GI side effects. And yes, you had less, well, it's about 6% having presented with GI side effects. 4.5% of them had diarrhea, nausea, and vomiting, and the other 1.4% had and that would be GI bleeds for the 1.4%. So we do have a good safety profile in comparison to the other molecules that you have to choose from. And yes, at this time when we do have concerns as it relates to our pediatric population, and we want to keep them safe, and I certainly say start with your first line of treatment, you can certainly understand that at some point you may have children coming in with with inflammation, where an paracetamol or acetaminophen would not be able to properly manage that child, right? And you may need to incorporate an anti-inflammatory molecule. Just advising that with cataflam, we do have good safety profile with the pediatric population. We do have flexible dosing, and that is why we are we do have flexible dosing for from baby straight up to 99, right? So we have the cataflam drops, which is 1 drop per kilogram, 3 times, well, every 8 hours. And for the suspension, for the older children, older than 3 to 9 years old, as well as we have the 25 milligrams for children who are older than 8 years old, and depending on this dose, this weight dose here, which is a 0.5 to 2 milligrams per kilogram per dosing, that can also determine which presentation that you utilize with the children. We have the newer presentation for our adults, which is the cataflam liquid capsules. And lastly, just a slide here compiling all the presentations that we have here at Novartis. And this is the end of my presentation. Thank you so much for having me.
Just want to say a big thank you to Ms. White for sharing with us this afternoon. I'm sure we were all made aware of some of the issues and some of the things that Novartis has to sort out to sort us out as a sponsor. We're still doing good with time, and we have only one more presenter, and we know you would not want to have missed the legacy of COVID-19 in our children, and I know that is why we still have over 100 participants still with us. And to do that to make that presentation is no other than Dr. Rochelle Crawford, or one of our senior residents in pediatrics here at the Spanish Town Hospital. She obtained her Bachelor of Science in Psychology at the Furman University in South Carolina, her MBBS at the UWI Mona, her DM in Pediatrics also at UWI Mona, and she has interest in developmental and behavior in pediatrics. She's also excited about reading, exercising, photography, and also, apart from dancing, going to the beach. So I want to make welcome Dr. Rochelle Crawford as she tells us about the legacy of COVID-19 in our children. Please make her welcome.
Thank you very much. Thank you. Okay, so this evening I'll be talking about the COVID-19 legacy in children, with specific focus on long COVID in our children. Just a quick recap on COVID. So as you know, the first outbreak was linked back to Wuhan, China in December 2019. We're almost 2 years into COVID now. 1 month later, there's evidence of human-to-human transmission in Wuhan. And then 3 months later in March, we had our first imported case in Jamaica. And in March 11, 2020, it was declared a pandemic by the WHO. Since then, we've had school closures, we've had work from home orders, we've had several curfews, other restrictions on things like going out, bars, gyms, etc. And recently, we've had our curfew scaled back from 11 o'clock to 8 o'clock now due to the current situation. To go on further, in April 2020, in the USA and in the UK, we had MIS-C, or the multi-system inflammatory syndrome of COVID. We've had a few cases here at Spanish Town Hospital earlier this year, and this presents like a Kawasaki-like syndrome in which patients present with a rash, fever, and other manifestations post having COVID. Since then, we've had our alpha variant in December 2020, which was said to be more transmissible than the previous variant. It's not going. Oops, it's not going. It's not. Oh. Okay. Right, and since then we've had the roles of our vaccination programs, Pfizer, Moderna in the US, and here in Jamaica by our COVAX vaccination program, we've had AstraZeneca, we're getting more vaccines now. And as we saw in December 14, 2020, we had our first vaccine by a Jamaican nurse. She got the Pfizer vaccine. And here in Jamaica in March 2021, we had the first vaccination here with your AstraZeneca vaccine locally. Currently, the vaccination rate is now 6%. And in the US, it is much better, 49.7%. And in the UK, 70%. It's probably owing to several factors. Availability for one. You know, the first world countries have more availability owing to more money, so they can purchase more vaccines to vaccinate their population. Currently in Jamaica, we have had 51,930 active case rate of 16%, which has gone up recently since we have been having this resurgence of our COVID, and our third wave. Currently, we've had 1,179 deaths in Jamaica, and as of July 4th, 2021, we have had 183 million confirmed cases worldwide, with globally 3.97 million deaths. We've experienced a first wave last year, spring 2020, second wave later in the fall, and now a third wave, probably owing to the Delta variant was first noticed in India in December 2020. And now we're seeing something called long COVID. This is just showing a vaccine update on the Caribbean, different countries who have been vaccinated since the vaccination program began. As you can see, Cayman, Bonaire have had a high vaccination rate, with Jamaica, right around 6.16%. So we're not doing so great, but hopefully with the vaccines coming in recently, we'll have more vaccination uptake will be better. So what is long COVID? So it's also known as post-acute COVID syndrome, chronic COVID, long-haul COVID, or post-acute syndrome of SARS-CoV-2. The CDC describes it as an umbrella term for the wide range of health consequences that are present 4 weeks or more after infection with SARS-CoV-2, and they're both acute or subacute and chronic long COVID. For subacute, the symptoms persist for 4 to 12 weeks, post-acute onset of symptoms, and for chronic COVID, symptoms persist beyond the 12 weeks, and there's no attributable cause to these symptoms. Of note, we are seeing similar patterns with MERS and SARS, which occurred in 2012 and 2003 respectively. And if you can recall, these patients also had shortness of breath, they had fatigue, and it's also due to a coronavirus as well too. And patients who had experienced these symptoms had prolonged symptoms up to 4 years later, and had documented fatigue and shortness of breath afterwards. Typically in adults, so as you know, most of our research begins in adults, so they're able to document quite a few symptoms in patients who have had long COVID, and adults have been complaining of things like dyspnea, cough, rhinorrhea, chest tightness, they've had chest pain, palpitations, GI symptoms, they've had abdominal pain, diarrhea, vomiting, hyposmia, anosmia, no hearing loss. In adults, they've had joint pain, arthralgia, they've had headaches, fatigue, mood changes, or what is known as brain fog, or cognitive impairment, depression, of course, due to the number of deaths, members being affected in their family, anxiety due to isolation, PTSD, insomnia, rash, alopecia, all due to the stress of the COVID, and other things such as paresthesia, fever, and post-exertional dyspnea. In children, they have done very few studies, however, in kids for long COVID, but some common symptoms include dyspnea, fatigue, similar to the adults as well too. They've had palpitations, chest pain, joint pain, headache, and muscular aches and pains. With regard to the pathophysiology of COVID, this helps us to understand now how long COVID comes about. You have to go back to the pathophys briefly on COVID. So let's remember that COVID-19 enters the host cell and attaches to the ACE2 receptors. And this is found in all organs of the body, but predominantly in the lungs. It's also found in myocardial cells, kidneys, small intestines. And when COVID enters the body, it causes direct viral toxicity with endothelial damage and microvascular injury. There's an immune system dysregulation with a hyperinflammatory state which occurs and causes excessive recruitment of inflammatory cells like cytokines, causing a cytokine storm. There's also production of pro-inflammatory chemokines, and also this produces a hypercoagulability state and with microthrombi formation. And the end result is multi-organ dysfunction. This is just depicting the role of ACE2 in COVID, showing how it causes edema in the brain, it causes neuron degeneration, it causes edema as well too. In the lungs, it causes microthrombi formation, inflammatory infiltrates occur. In the pancreas, it causes focal inflammation, causes atrophy of the myocardial fibers. It's just showing how it's an extensive condition. For long COVID now, there have been studies done on human and mice brain autopsies post-COVID, which shows that SARS-CoV-2 replication occurs in neuronal cultures and brain tissues. The brain stem is said to express high levels of ACE2 receptors, and they've also found COVID-19 genes and protein in the brain tissue of deceased COVID-19 patients. They have found that COVID-19 particles persist and cause damage to the cardiorespiratory center in the brain stem. And they have also found that the neurons tend to regenerate very slowly, and this could lead to the long-lasting brainstem dysfunction that occurs and the CNS symptoms that persist for quite a long time post-COVID. Additionally, they have found that T-cell dysfunction, as you know, is one of the proposed mechanisms behind long COVID. And severe COVID tend to cause B-cell and T-cell deficiency, which causes hyperinflammation in acute COVID. As the B-cell and T-cell lymphocyte levels are restored after the acute event, there's inflammation which causes organ injury and later long COVID. And they found that pro-inflammatory markers such as your D-dimers and interleukin-6 and CRP are found in patients with long COVID several months after the acute incident. So this therefore manifests basically as pulmonary fibrosis in the lungs. They have ongoing myocardial inflammation with myocarditis. There are thrombotic events such as pulmonary embolism, intracardiac thrombus, ischemic stroke. They have microvascular thrombosis and neurodegeneration. acute kidney injury as well, and pancreatic injury seen in patients with long COVID. They have also found that in these same patients, fecal shedding can occur up to 2 months after COVID, and they have found respiratory tract, COVID in the respiratory tract system up to 4 months later. So in children, as I mentioned before, it's generally underreported in kids, and there have been very few studies in children less than 18 years. But since parents have been coming about and bringing light to this condition, support groups have emerged since that time, documenting the parents and their children's experiences with long COVID. And a website called Long COVID Kids you can check out to see what parents have been documenting. This, of course, is mainly in the US, not in Jamaica here, but it's good to see what other parents are experiencing overseas. And because of this, more kids are presenting to the evaluation for symptoms of prolonged COVID infection. So just to go into a few studies, in the UK Office for National Statistics has reported almost 500,000 children in the UK had tested positive for COVID since March 2020. Of that, 12.9% were 2 to 11 years, 14.5% were 12 to 16 years, and still have symptoms 5 weeks after their first infection. Common symptoms include lethargy, headache, palpitations, and GI symptoms, and they have difficulty in returning to school. There's actually one mother who documented that her child 6 months post-COVID had still not gone back to school because she was still lethargic, she was having dystic episodes, and every time she went out to do her regular activity, she became extremely fatigued, and so she's just been at home doing homeschooling. Five children, 15 years of age, me 1 boy, none of which had required admission to hospital, but one patient had a chronic illness which had asthma and autism spectrum disorder and allergies. They had a clinical diagnosis of COVID-19 with similar symptoms, fever, dyspnea, abdominal pain, headache, and extreme fatigue. And they had symptoms that had persisted for 6 to 7 months post initial diagnosis. They also had palpitations, memory loss, abdominal symptoms, and the patient who had asthma and autism also had a perimyocarditis, requiring admission to hospital for that condition. These patients were tested with ECG and echo, all of which were normal, but they had continued to have impairments in the activities of daily living post-COVID. This is just basically showing the characteristics of the patients who were evaluated. As you can see down here, patient 1 was in bed for 3 months, patient 2 was sick for 11 weeks, was depressed and angry. Patient 3 was constipated, fatigued, stayed in bed till noon. These are parental reports, of course. Patient 4 had extreme fatigue, no strength to speak. Patient 5 was in bed, had slept for 16 hours per day, had dyspnea, chest pain, and dizziness. And this is just going again, the parental reports of these patients. In Italy, they had a study done with 109 known COVID positive patients who were interviewed at different stages of their post-acute COVID stage. They had found that 74.4% had symptoms, 25.3% were asymptomatic, and 4.7% were hospitalized. Of that, 35.7% had 1 or more symptoms, and 22.5% had 3 or more symptoms. And these, again, common symptoms were insomnia, respiratory symptoms, nasal congestion, fatigue, and difficulty concentrating. Again, just documenting the common conditions. So you can look on the column on the left, we're seeing where patients had commonly fatigue, insomnia, headaches, lack of concentration, persistent cough, etc. In Amsterdam, with 89 patients between 12 to 18 years, median age was 13 years, and they had confirmed COVID by PCR testing. Most common complaints in these children were fatigue and dyspnea. And here again, common symptoms had chest pain, stomach ache, myalgia, diarrhea, dizziness, brain fog, weight loss. Common complaints again amongst our children who are post-COVID. So this particular study, they had their patients being investigated extensively. They had CBC done, UNEs, LFTs, thyroid function tests, ECG, Holter monitor, they had echo, CT chest x-ray, all of which were essentially normal except for one patient who only had right axis deviation on ECG, but stress ECG was normal, and other investigations were normal as well too. So possible risk factors for long COVID. So for adults, they say that risk factors include increasing age, high BMI, females, and more than 5 symptoms during the acute COVID phase. bronchial asthma, and increased blood and D dimers were risk factors for pulmonary dysfunction. In lung children. Most of the guidelines are by the CDC for adult patients, and they're guided by the history and physical examination. Basic lab tests include CBC, UNEs, LFTs, CRP, your inflammatory markers, ESR, TFTs, vitamin D and B12 levels. They do specialized tests if you have any joint complaints, if you have any myalgia or any arthralgia, it can be ANA, rheumatoid factor. If you have any chest pain, you can do troponin for any myocardial injury. Additional tests can be requested as well if there is persistent or new cardiac or respiratory findings, such as the chest X-ray, CT chest, ECG, and echo. Most of these tests, as you have seen, have come back normal, however, but I guess it's better to just evaluate to err on the side of caution in these patients who have these excessive complaints that are persistent for quite some time. Other tools for investigator management include their assessment tools, again, primarily in adults. So there are scales that you can do to assess their functional status, seeing how well they're able to move around, if they have difficulty doing the regular activities of daily life, such as walking or going to the bathroom, eating, etc. There's a PTSD symptom scale. Of course, patients who have experienced a death in the family or ICU admission would have some trauma from those events. The fatigue severity scale, and their exercise capacity tests as well to assess how well they're able to walk without becoming breathless. Other goals of management to optimize the function and quality of life include basically having a multidisciplinary approach with specialist teams, devise a proper treatment plan based on the patient's medical and psychiatric history and their social circumstances as well. So they recommend doing rehabilitation for these patients with physical therapy, occupational therapy, speech therapy, vocational therapy, for example. Outpatient management would include for patients who have pre-existing medical conditions to improve your nutrition, sleep, stress reduction, doing meditation. And they're also suggesting a patient diary for symptom triggers. So for example, patients who have headache, fatigue, chest pain, they can document when these events come about, what triggers it, so they can know how to avoid these symptoms at the next event. And of course, with any outpatient center, they recommend follow-up visits every 2 to 3 months to ensure that these symptoms are either resolving or improving and how best to manage them afterwards. And of course, not to mention our support groups, which they symptoms, the children, they have the adults, but still support groups are always good to help in your rehabilitation process. And our curfew is just on the health system alone. Because patients have chronic ill health and increased quality of life because of COVID and being hospitalized. They can't return to their normalcy afterwards. School closures, of course, that is a big stress on the parents, which affects the children's learning. And remember, those who have from the lower strata society, they are disadvantaged because they have no tablets or cell phones to gain access to lectures. Of course, they're falling behind in their schoolwork. Not to mention the lockdowns and curfews. So people who are pre-existing mental health illnesses and depression and anxiety, these are exacerbating more in these patients with these conditions. And of course, we have to look into addressing their mental health. Not to mention things like crime, abuse in patients, people which we're seeing more often now. Kids are being physically abused, sexually abused. We saw the little boy who had passed away just last week. So it is taking quite a bit of COVID. So thank you very much. These are my references here. And yes. Not even, sorry.
Your presentations. At this time, I'm going to be calling again the duo of Dr. Patterson and Smith to come, Dr. Smith and Dr. Clark, to come back with the questions and answers. I think there are a few questions that are in the chat. I'm still asking that you put your name in the chat once you want, and your email address once you want your CE hours, and also that you continue to fill out the questionnaire. Now, now ask Dr. Smith and Clark to come, and this will be followed by Dr. Stuart Murray, because he's going to give the vote of thanks for all these presentations that we have heard for the afternoon. Over to you, Dr. Smith and Clark.
Tired, huh? Tomorrow, supposed to be meeting with the RD. Yeah, but I'm leaving at. Okay.
Right. So I'm not sure, but that's something to look into to see how the kids have been affected by the parental loss. I'm sure it has been quite tragic for them and has been an adjustment, but I can look into it and get back to that. Right, so what happens is that initially COVID causes the B cell and T cells to be deficient, but then post that event, when persons are experiencing long COVID, there's a reactivation of B cell and T cells, which causes hyperinflammation again, and that in itself can cause symptoms of a long COVID.
Openly, if there's anybody who wants it. Yes, hi, Robert. Yes, hi.
Okay, good Good afternoon, all participants. I'm sure you will agree with me that this was 3 hours or so that was very, very well spent. Testimony to your newly learned time management skills. Okay, so times like these are things that are important and that are very, very necessary in terms of time management. So all good things must come to an end, and we have come to an end at this point in time for our webinar on lifestyle, legacy, and new norms. And it falls to me to give the vote of thanks. First of all, let me start by giving thanks to the Heavenly Father, without whom none of this would have been possible. And moving on from that, I'm sure that you will all agree with me that all our presenters were excellent. You know, informative, educational, stimulating, and very, very practical. All right, beginning with Dr. Joseph Morrison, because we had presenters from Yard and from abroad. Dr. Joseph Morrison is one of those from Yard, our own pharmacist, chief pharmacist here. Very, very well done. And you do well to take home some of the things that you have said in terms of advantages from switching from IV to PO, not the least of which is cost savings, because money is very, very short in these times. Secondly, so thanks a million, Dr. Josette Morrison. Appreciated, and we look forward to having you again and again and again. We won't tax you too much because we are well aware of time management constraints. Dr. Bentic, very well done. I had to dust off some of the old archives in my brain to get familiar with a lot of what you were saying, but thanks for that wonderful presentation. I didn't know that migraines could have been one of the presenting features of COVID, and indeed how COVID impacts migraines in general. So thank you for that reminder. And I also learned another thing, that you are from Guyana. I didn't know that. And I have a special place in my heart for Guyanese because my mother-in-law is Guyanese. So, you know, we can speak off the air on that later. So thank you again. This is somebody again from Yard. Now from abroad. When we went abroad, no, we didn't just go pian or fenke. We went for the best of the best. Dr. Simone Dundas Biles on time management, strategic time management for busy medics and for others. You know, I've known Simone for a long time, Dr. Dundas Biles, and I've often said that when I grow up, I want to be like you. All right? You know, it was very, very, very well done. And there's one thing I disagree with you about, though. The day, a normal day contains 24 hours. But, you know, there are persons, there's one particular person sitting in our midst whose day contains 30 hours. That is Dr. Wright James. All right, so maybe we can take a page or two out of her book. So thanks again, Dr. Dundas Biles, for your timely reminder and pointers. Moving on to the legacy of COVID-19 in our children, our own Dr. Rochelle Crawford. Where is she? Yes, thank you again. Well done. Thanks for reminding us that even though COVID may have come and gone, it is leaving, it can leave a lasting legacy, and we probably won't know the full story until maybe another couple of years have passed. So thanks for that. And that is even more reason to be very careful, very vigilant, observe our protocols, get vaccinated so that we can mitigate, prevent, you know, some of the effects that COVID can leave with us. And again, our sponsors, we want to thank Novartis for sponsoring us, sponsoring our lunches, and also for that presentation by their rep, Shoshana White-Smith. Thanks again, Shoshana, for engaging with us. And we know it's not the first time you have done so, and we look forward to engaging with you in the future. So thank you so much, Novartis and Mrs. Whitesmith. Okay, now an event such as this, a webinar, it involves so many persons. You'll be surprised. When it is run well, you don't quite appreciate some of the behind the scenes persons and things that are going on. But trust me, you know, we require the assistance, the able assistance and input and hard work of the team, most ably headed by Dr. Wright James, who, as we have said before, has 30 hours in her day. So she has more hours than us to begin with. But the rest of us mortals, you know, also have to be thanked. So let me start off by looking at one. There's this company called Venue Optimization and Decoration, who's responsible for the decor. All right, and that company, the principals are Dr. Wright James, Sister Marika Powell, and the postnatal nurses. And they have so ably decorated this place for us. So, you know, if you have any events to be organized, places to be decorated, you can call upon them. I am their agent, so calls can come through me. So thanks guys. And then we had our Millennial IT Services, most ably headed by Dr. Anita Beckford. All right, give her a round of applause for being so integral and so essential in terms of doing all of this in our sense of industry and community service has no bounds. So thanks again, Dr. Beckford, most ably assisted by her team, Dr. Mackenzie, Dr. Scarlett, Dr. Pattison, Dr. Smith, Dr. Clark. All right, so well done, well done. And you know, we are just so grateful, so thankful to you all for the wonderful input, you know, to have achieved this great output. And last but not least, how could I forget our most esteemed, venerated DNS of the Spanish Town Hospital, Matron Novelet Robinson, who was our chief moderator for the day. And I'm sure you'll agree with me that her style and the tone that she put forward, you know, the upbeatness of her introductions, etc., you know, are incomparable. And she's another person whose day, it might not have 30 like Dr. Wright James, but I'm sure it has 29 or 28 hours. While she was here, she was multitasking. So as soon as she was doing her moderating and had a little break, she was there signing and looking at this and looking at that. So, you know, we just want to thank you, Matron DNS, for engaging with us and so ably managing the program that we have presented. Once again, thank you all participants, because without you all, it would have been pointless. And we had a wonderful turnout. What were the numbers? 145. So kudos, thank you to the 145 persons who logged in and participated in this, our webinar. And, you know, long may it continue. And well, not now, but at the appropriate intervals. Every 3 months, quarterly. Okay, so stay tuned for the financial series coming up at the end of August, and we look forward to see you. Remember, CMEs are important. So please follow the instructions in the chat. Signing up via the Google document via the link that was shared so that you can get your CME. So thanks again. I don't know if our esteemed DNS has any last remarks, so I'm handing over to her. Thank you all again.
And a big round of applause Dr. Stuart Murray for thanking everyone. I thank Dr. Murray for thanking everyone this afternoon because, of course, when people work, you want to feel appreciated. And he did just that. I want to remind you I want to thank you too for staying the course of the 3 hours. It's not quite. To remind you to register for the CME hours and also to complete the survey because we want to be able to give you something, just what you asked for apart from the financial one coming up next. We want to plan ahead to suit your desires. But of course, you know, I can't afford to let you go without giving you a little bit of laughter because I'm in so many groups and I keep leaving the groups. You know why? I'm just so desperate to get out. So I I just leave the groups and then they have to add me back. But never mind that. But never in my wildest dreams have I ever imagined that entering the bank wearing a mask and asking for money and not being locked up after that. Lockdown seemed like a Netflix series. Just when you think it's over, they release a new season. Just this week, a new season was released. I'm starting to like this mask thing, you know, because I went into the supermarket yesterday and 2 people that I owe did not recognize me. Those complaining that we didn't have enough holidays, what now? I need to social distance myself from the refrigerator. For those who know me then, you would never realize, but I've been tested positive for overweight. I have not added 2020 to my age because I didn't use it. I don't even know what is going to happen in 2021. I want to publicly apologize for the year 2019 and all the bad things I said about it. And to all you married women out there, praying for your husbands to spend time with you, how are you doing? My washing machine only accepts pajamas these days. I put in a pair of jeans and the message popped up, stay home. In 2019, I avoided negative people. In 2020, I also avoided positive people. In 2021, I avoid people because I don't know if they're positive or negative. I just can't wait for 2022. Ladies and gentlemen, it was my pleasure to have chaired this session this afternoon. I'm sure you made the switch from IV to oral. You were able to manage your migraine versus COVID-19 and migraine. You were able to reclaim your time and manage and had strategic time management. And in the end, we have the legacy of COVID-19 in our children. You were a great audience. Have a good evening. Dr. Wright James would say. Welcome, my dear.